I think shades of gray is probably a better term, because Kristen and I are on the same wavelength, so to speak. Anyway, thanks for inviting me this morning. The pediatric birthmark area has been a very big part of my life, my practice, and it's been a great goal of mine to improve what we can do on treating these patients. So the title of this is supposed to be What Comes Next, and I think early intervention is item number 1. Adjusting treatment intervals is number 2. Larger spot sizes in treating these kids, improved cooling techniques, and perhaps pre-treatment and intraoperative imaging, as Kristen was just talking about. So why do we treat these kids to begin with? And one of the reasons we treat these kids is to prevent progression. And aside from the psychological benefits, which is clear, these kids, I think, are better adjusted. They feel better about themselves. The families feel better about their children. To not have something so visible, but the thickening that occurs can become problematic in some of these kids continue over time. And this is a patient over a 45-year period. You can see the progression a bit extreme, but we do see this in 2/3 of all patients by the age of 45 or so, where there is a high number of them who at least get some papules or some nodules that can occur over time, and they can bleed spontaneously. So this is what we can achieve. You can get significant clearing. By the way, that's a little bit of eczema on the forehead. You can treat the eyelids. We use protective ocular shields. I do avoid the hair when they're very, very young, as this could lead to some prolonged alopecia, which bothers the families, even with light hair. Even using a vascular laser, you can get alopecia. So many people are concerned about putting protective eye shields in. I do this all the time, so for me it's easy. I encourage those of you who are treating babies to learn how to do this, or adults, because it can make a very big difference, because you don't want to eliminate the treatment of eyelids or the area around the eye. Many times some patients come to me have been treated elsewhere where the face is cleared nicely, but the eyelid area and the perioral ocular area has never been treated. So I think that's a mistake and can be treated effectively. Now, we had published this in 2019, looking at a large number of patients, 197 patients under the age of 1, and our numbers are actually much higher than this at this point in time. This is just the number of patients that we had follow-up on that point in time. So we're dealing with hundreds and hundreds, if not more, of patients who've been safely and effectively treated. And you can see the degree of clearing that we achieved and the degree of lightening overall. So, and I think some of the patients who didn't improve as much were some of the patients with extremity lesions, and I think there's a way around that as well. One of the advantages of treating these kids when they're very, very young is you avoid the concerns that the FDA has with exposure to general anesthesia. So many of us, including myself, have been treating these young children with general anesthesia under the age of 3, and there are neurocognitive concerns about treating these kids multiple times. And then many people have also been concerned about how uncomfortable these treatments are, and are we doing something that's so painful and damaging to these children? And we've done a couple of studies that have shown that this is not painless, but it's not necessarily a horrible thing for these children. So we did a tolerance study looking at 47 little babies and under the age of 2. We did 2 validated pediatric pain scales, the Evandel and the PPPM, where the parents and the staff evaluated their perception of the pain the child had experienced during the procedures. Interestingly, the placement of the eye shields did not impact pain tolerance. So our conclusion from these treatments is that the office treatments without anesthesia was well tolerated. Many of the kids that I treat when they leave the office or complete the treatment are okay by the time they leave the treatment room, certainly by the time they leave the office. So how early can you begin? I believe in beginning from day 1, if possible. Fortunately, families are savvy. They go to the internet and they find that early intervention is possible. Many pediatricians, many pediatric dermatologists don't support this or even are aware of it. But patients are sending themselves in, by and large, and this makes a very, very big difference. This is the preemie that I treated early on, 10 days before the birthday, who did very, very well. But more recently, we've looked at treatment intervals, and we've begun to treat weekly. And one of the reasons we're treating them weekly is that we're not getting purpura during the first few months of life, even with relatively higher energies. So you can see here 2 months and 6 months, considerable clearing, in many cases complete clearing. Skin of color, very, very nice clearing, almost clear on one side of the cheek, a little bit remaining on the other. Here again, pre and post, 5 days and then 4 months. And this allows us to treat the extremities much more effectively than we could before. Treating the distal extremities below the elbows, below the knees have been extremely challenging. Here we're able to treat these little babies much more effectively with early intervention. You can see here body involvement 5 days and then at 4 months. So this will be discussed in greater detail by Dr. Tao later in the session, but we did have dramatic clearing, as you can see here, pre and post treatment. And the other advantage to what we're doing is we're using larger spot sizes, we're using relatively high energies, and this allows for a faster treatment. So at 2 months, 75% of our patients had achieved near total clearing with this approach. And this is what we see immediately post, really nothing. Just some mild redness following the treatment. So as these patients do become more purpuric during the treatment, we begin to extend the intervals. And here you can see that the results are quite dramatic and something that we encourage you to consider shortening the treatment intervals using these larger spot sizes that's available to you, and certainly will be available as time goes along. Now, we published this along with Paul Friedman's group using a larger spot size PDL, and not only did we have faster treatments, but we saw more clearing as a result of these treatments as well. So whether it's a young child or an adult, we do recommend using these larger spot sizes, and you can see the speed alone makes a very big difference. So on a practical basis, it makes it so much easier to treat these patients, particularly these young children. So there's less of a concern about them moving during the course of the treatment. And of course, there's, as was mentioned earlier, using a 532 nanometer wavelength with another device with their large spot size as well. You can see the deeper penetration, the more extensive injury. And this uses not only the pre-cooling, but post-cooling as well. And this is something that's now available and will be available with the newer Candela device with the pulse dye laser. And we have found that the post-cooling dramatically diminishes the pain. So another reason to allow us to treat these young kids more effectively. Recalcitrant lesions, we mostly see this in adults. We've been combining this with radiofrequency, with microneedling, getting some of the thickening that presents us as a problem, but even in the teenage population, if you have a resistant lesion, this could be a benefit as well. And again, I don't want to belabor the point, as Kristen discussed this in great detail, but I think as OCT becomes more familiar to us and easier to use, this can be used as a guideline for imaging and for choosing the parameters in which we treat the port wine birthmarks that we see. And you can see here, one of the things that we found is that these blood vessels are very heterogeneous. The birthmarks are all over the place in terms of the depth and the size of the vessels. So as we begin to learn how to treat these more effectively, I think OCT will be used more appropriately and more frequently in a method to adjust our pulse durations, our spot sizes, and perhaps the wavelengths themselves. So where we're going in the future, I think the bottom line is that early intervention makes a big difference. Shorter intervals of treatments, imaging can play a role, and post-cooling can allow us to treat these patients more easily and more effectively as well. Thank you very much.